Good evening, everyone. Welcome to session 17 of the SCTS Foundation Doctor Academy teaching program. I'm delighted to be joined by Dr. Tom Pierce, who's a retired but still enthusiastic adult and pediatric cardiac anaesthetist, who's going to be talking to us about cardiac anaesthesia and intensive care. I'm sure will be a very exciting talk. We've covered valvular disease, coronary disease, cardiopulmonary bypass. So this will be really the anaesthetic and intensive care parts of the patient's journey. Without further delay, over to you, Dr. Pierce.
Why, thank you very much indeed, Hanad. I can't see any of you, but I hope you can hear me clearly. And I'm just going to talk about anaesthesia and cardiac surgery. I don't intend to teach you all that you need to know about being an anaesthetist. But I would hope that one of the things that will come across today is the importance of the intraoperative relationship and the postoperative relationship. I've had the pleasure of working for 30 years in Southampton, whereby when we started, I have to say, my colleagues and I, we had a little difficulty getting our surgical colleagues to see eye to eye. But bit by bit, and with good quality anesthesia and perioperative care, I have to say, I'd like to think we won over our surgeons, and the surgical and anesthetic relationship grew and flowered, so much so that we had one of the finest results. And I think the finest results relate to not just the clever technology that you do, but the sharing of ideas about what we should be doing together for the individual patients. Now, increasingly, that involves the preoperative side of it, but that relationship in the operating room and postoperatively is so vital. And when I think back on my career of the opportunities where a bit of blue sky thinking has pulled something out of the box and changed the postoperative course for patients, I look back with perhaps a little bit of quiet admiration. So let's move with putting that aspect to one side, and perhaps I'm going to move on to some technical side. One of the points that I often make for my younger anaesthetic trainees is there are two terms, both with bypass in. Now, you understand that a coronary artery bypass graft, a CABG, is an operation, but you also understand from this series of instructional sessions that you've had that cardiopulmonary bypass is a technique to maintain the circulation. And it really refers to the passage of blood that doesn't actually make its way back to the right atrium, but traverses the circuitry and then ultimately returns into the aorta. And with the term bypass can be used interchangeably between the two, and therefore quite not unusually causes confusion. Now, what do we think about the goals of cardiac anaesthesia? Well, the first thing is we've got to have an unconscious patient, a patient that is asleep and oblivious to what is going on. That's our job. But we also need to make sure that that patient actually is alive. And what we're trying to do is we're just going to try and think about that in terms of the setting. We need to think about the maintenance of oxygenation and stroke volume prior to bypass. In other words, with the diseased circulation. And that's where handling the circulation in the anesthesia perspective is so vital. We have to think of the components of how we're going to cajole that circulation through that period of surgical dissection and get that circulation ready for cardiopulmonary bypass. The next page is when you are actually doing the surgery. In other words, the maintenance of oxygenation and perfusion during cardiopulmonary bypass. In other words, the task that is normally the responsibility of the perfusionist. If any of you go to Australia, you will find that the perfusion is run by the anaesthetists. They have 2 anaesthetists per case, one on the anesthesia side and one on the perfusion side. we've also got to factor into that, and this is really of relevance when we're thinking about the global care of that patient, is that perfusion going to the right sort of place? Because whilst the perfusionist gives a global oxygenation or oxygen return, is it going to the bits that really matter? And hand in hand with that, and once we're on bypass, the most important thing is to preserve the heart's function and that of the mechanism of cardioplegia and how that works. And then when all is said and done, and the surgery's been done, the valve has been implanted, the grafts have been formed, we then have to think about the maintenance of oxygenation and stroke volume after bypass. In other words, the maintenance of DO2, oxygen delivery to the tissues, after the you surgeons have done your bit. So it's all to do with DO2 and organ perfusion. So if there's going to be that, if we're going to think about DO2, we've got to think about the things that matter. In other words, stroke volume. And of course, stroke volume comes down to three really important physiological variables: preload, afterload, and contractility. Okay. Now, preload is the myofibril stretch, the actin and myosin. If you can imagine that they're interdigitating, the further they get stretched, the greater the area of chemically active surfaces available for activity, and the greater the contractile performance. So we know that filling a ventricle appropriately makes the stroke volume better. The point about afterload is it's one of those funny things that people said it trips off the tongue. So I've got therefore a definition for you. And I think of it really as like going to the gym. Okay, you're in the gym, you're picked up a 3 kilo weight and biceps flexes. Equally, you go to the gym and you pick up a 25 kilo weight, and then your biceps does its damnedest to flex and probably doesn't. And of course, the difference between the two is the afterload. In other words, the tension that needs to be generated before muscle shortening will occur. And I think this is a really useful definition of afterload. Think of it on a bicycle. You're pedaling downhill. The tension that needs to be generated before muscle quads shortening occurs is very low going down a hill and higher when you're going up a hill. So it's the tension before shortening. And as far as contractility is concerned, it was put to me once by a lecturer in physiology, and I can remember this gentleman exactly because he gave me the most brilliant definition of contractility as the springiness of the spring. And why do we want it to be the springiness of the spring? Well, the heart contracts, yeah, it does, and it's ejecting its stroke volume. But of course, it has to relax to accommodate the next stroke volume. So when you look at a heart that is pumping well, it's like an athlete in a marathon springing towards the finishing line. In other words, it's contractile function and there's relaxation. And that's the two go hand in hand. Watching the heart inside a chest, there's almost a twisting rotational movement as the heart tensions and relaxes and flops back again. So those are the physiological components of stroke volume. But in pathology and in surgery, where we're dealing with correction of that pathology, we have to put into that regional wall motion abnormalities, muscles don't work quite so well, and valvar dysfunction. Because we've got the 3 physiology and 2 pathology. This illustration has been churned out in physiology textbooks ad nauseam. And in the top section here, we see the arterial waveform, okay, dicrotic notch, diastole. And we cannot forget that the coronary perfusion, and particularly the left coronary perfusion, is dependent on this pressure here, because those coronary arteries during systole are squashed closed, because they run perpendicular to cardiac muscle, and so flow doesn't occur then. Those phasic changes of right coronary blood flow are not nearly so marked, and that's because, of course, the pressure within inside a right ventricle is about 1/6 of that in the left ventricle in health. It doesn't always apply, but in health, it should be about 1/6. And think about it, 120/80 versus 25/12 or 25/8 as pressures inside pulmonary arteries and systemic arteries. But if we're thinking about the time for when perfusion occurs, we have to think about the relationship between the heart rate and time spent in diastole. And that relationship is not, is not a straight line relationship. It's a curvilinear one. But if you could remember that at a heart rate of 75, around about 30 seconds per minute of time is spent in diastole. In other words, 50% of the cardiac cycle is spent in diastole. So in other words, keeping the heart rate slow optimizes the time by which blood can flow down coronary arteries. I'll show you some examples of how in the course of my career I've got that wrong once or twice. So very often when you're faced with, oh, what's the best inotrope? I would always say that the best inotrope is that which nature has given us. In other words, it's a fully oxygenated red cell flowing down a coronary artery. And when we're thinking of flow down a coronary artery, we've got to think of either the physics of flow, whereby flow is related to the fourth power or is related to the fourth power of the radius, that's Poiseuille's law. Or if you're stuck, and we might come back to this later on, we might have Ohm's law from your time spent at school and doing physics or chemistry, or predominantly physics, where V, the pressure, is I, the current or flow of blood, multiplied by the resistance. So an oxygenated red cell is great. So the oxygenated and red cells depends on the number of them as well as the saturation. So that defines what we call the content of arterial oxygen. We've already seen how the time for coronary perfusion is related to the heart rate, 50% of the time in diastole at a heart rate of 75. But we've also going to factor in something called the coronary perfusion pressure, which is, of course, the aortic diastolic pressure minus the LV EDP. So this is the pressure that is driving blood down the coronaries, and this is the pressure at the other end of the coronary tree. And then we can think about the coronary vascular resistance if we're thinking about Ohm's law and the resistance in a physical electronic circuit. So you can think about that in terms of the minutiae in a coronary artery, which might be the contents, a clot, or an atheroma, or it might be the wall, or it may be extrinsic compression from other sources. The history and the preoperative assessment is something that you've probably done many times before, so I'm not really going to dwell on it, other than to say there is really little excuse for not taking a history, examining the patients we're responsible for, and then looking at those investigations. It's really important. And when we're thinking about the history of pump failure, your heart, so it can either, there's only 3 things in the heart that can go wrong. The muscle can go wrong, or the valves go wrong, or the pericardium goes wrong. And when we're thinking about the muscle, it could be ischemic or infarcted. It could be acutely inflamed, or there may be a chronic cardiomyopathy. Those are the 3 things that affect pump function. And in the picture here, I've got a beautifully sort of excised, calcified 3-leaflet aortic valve with some senile degenerative calcification. And if my memory serves me correctly, this was excised by Steve Livesey, with whom I worked for a very large many years. It's rather beautiful, isn't it? Quite incredible, isn't it? I always think for the most part, this thing opens and closes 70, 100 times a minute for 60 or 70 or 80 years without causing any grief at all. What a design. Just think of that. Hey, those investigations. Well, there's the general investigations and the specific ones. Now, the general ones are really very important because it's going to affect how the conduct of anaesthesia and perioperative care is managed. I've taken an example here of someone with myelodysplasia. They had a low hemoglobin, low white cells, and low platelets. So you can see the importance of augmenting the hemoglobin concentration in the perioperative period, watching out for infection because of the immune compromise, and topping up the platelets. Patients with renal failure or impairment of renal function, and in this case, someone with nephrocalcinosis, has preoperatively elevated urea and creatinine, and surprise, surprise, by postoperative day 4, both of those have increased still further. And you might be able to say or factor in that the likelihood is that you'll need a period of renal replacement therapy and consent the patients appropriately. We always look at coagulation screens because coagulation screens, whilst not always abnormal, we are going to render them abnormal with cardiac surgery and into the postoperative period. So it's always really useful to have the baseline. And in specific investigations, we'll have a look at one or two of those here. This is an 12-lead electrocardiogram taken from a patient who has clearly had an infarct affecting, that's given him Q waves in the anterior septal leads with some T wave inversion. And so you would conclude that they've had a full thickness myocardial infarction some time ago, not recent. And more importantly, because of our knowledge of coronary anatomy, we would probably bet our bottom dollar that there was an acutely occluded left anterior descending coronary artery. Now, this is an investigation that you possibly don't see that much of, but it's a section from an exercise electrocardiogram. So connected up to a 12-lead ECG, the patient is progressively exercised. And this is the heart rate over time. So we've gone through about 5 or 7 minutes of exercise, and the heart rate has got up to about 100. And as it does so, the ST segment here in this case, it's lead 2, comes down here. And once they get to recovery, it slowly normalizes. And looking at the magnitude of that ST segment depression, here we're looking, this point here at resting conditions, minus 0.9. And here it's minus 2.8. And the point at which that's measured is sometimes it's either 60 or 80 milliseconds after the J point. And the computer here has indicated to us the J point as being the junction between the QRS complex and the ST segment. That's the J point just there. So that's a positive exercise test. You may not see those, but they used to be done quite widely. And equally, you may not actually have seen this. And this is an image of someone who has undergone isotope imaging. And in this set of ones here, these are 2 stressed images, and these are the recovery images. And if you can imagine, we've taken a donut. So we're only seeing the left ventricle because of the uptake of tracer. And we can see that there's a perfusion defect posterior laterally, which would correspond to the obtuse marginal, one of the obtuse marginal coronaries. And if we look at that in longitudinal section, so this is the septum, this is the free wall, that's the apex of the left ventricle. There's a similar defect here posterior laterally. And those both fill in and recover. Well, nobody's going to do an operation on the strength of an isotope scan, but there we go. Perhaps, though, you're more likely to see these images, which are enhancement patterns or late enhancement patterns in patients having cardiac MRI. Now, gadolinium goes, as it's taken up equally into both normal and injured myocardium. But in normal myocardium, there'll be early washout. So you get residual gadolinium in the injured myocardium. And here's an example of a subendocardial infarction here, affecting the posterior aspect of the left ventricle. And here's a full thickness infarct here, both anterior and around the apex of the left ventricle. And that's a transmural infarct. And the time between the injection and the subsequent enhancement is 10 to 15 minutes or so. Sometimes we may have a referral that's come by a cardiologist, and here's some cardiac catheter data. So the patient has had both a right heart and left heart catheter. Now, whilst the left heart looks reasonable, the left ventricle, or perhaps a little bit hypertensive, but the aortic pressure is equally hypertensive. That makes you think there isn't a problem with the aortic valve. But glance over here. You remember that I said that the pulmonary artery should be about 1/6 of this. Well, gosh, it's not. It's above 1/4. And so this value here of a normal pulmonary artery pressure should be 25/8. And the right ventricle, similarly, is generating a higher pressure. And there was wedge pressure that's been done over here. Now, the wedge pressure, of course, should represent the left ventricular end diastolic pressure. But glance at this. The left ventricular end diastolic pressure is 12, yet the pulmonary capillary wedge pressure is 20. So there's an 8 millimeter gradient across here in the setting of pulmonary hypertension. Indeed, when we calculate the relative resistances of the two circulations, we can see that the pulmonary resistance is higher than it should be. And the diagnosis here was an obstruction at the mitral valve, and this patient had mitral stenosis, probably secondary to rheumatic heart disease during their teenage or childhood life. So there's some interesting data that comes out there. A left ventriculogram, I'd like to think that my left ventricle looks like that if it was being measured. I'd like to think I had a stroke, an ejection fraction of 76%. I'm hoping it stays that way so long as I keep on my bike. And of course, many of you have had a chance to see angiograms during your training, taken in either of the right coronary artery, I beg your pardon, or the left coronary artery. And I've indicated these vessels really for the benefit of an anaesthetic audience, because they may not be familiar with that anatomy. Well, one of our tools that has changed out of all recognition in the course of my professional life over the last 30 years has been the introduction of transesophageal echocardiography and the unbelievable images we can now obtain from those. And here we go. Remember that the left atrium is a posterior structure and is closest of all to the esophagus. So the point at which our image is taken as left atrium here, clearly this is the mitral valve, which is open in this stage. The left ventricle is tucked down here, and the right similarly over this side. And the right atrium, when we're looking at this sort of image, very often comes out of the field of view. This is an apparent hole, which isn't really an apparent hole at all. That's where the aorta sits. So don't be fooled into thinking that that's a ventriculoseptal defect, because it isn't. And we've used the opportunity that we have to change the angle at which we're imaging. And I've illustrated this in this image here. So this is one taken at about 122 degrees. And we've got a long axis view from the left ventricular outflow tract up the aorta here, with this mass of vegetation sitting above the aortic valve. And when we turn through a 90 degrees from this point here to this sort of angle, we'll not surprisingly then see this in short axis. So here we've got a vegetation sitting on the aortic valve, and this was stretching up into the aorta, and this patient had endocarditis. I can't tell you what type or what the bacteria was, but they clearly were having surgery at the time. Now, I mentioned to you already this evening the importance of regional perfusion, and the regional bits that matter to us are guts, yeah, kidneys, yeah, but brains very much so. And we have an opportunity to put near infrared spectroscopy on many of our patients. And these are normal values. There's often a difference between the two hemispheres, but let's be fair, that's not too bad. Why is it? The trouble is it's global, and that's part of the problem. It's not going to identify a small clot winging its way up from the aorta or a piece of atheroma flying into the cerebral circulation unless it affects the circulation in its entirety. But you can see there have been, in this particular instance, on both cerebral hemispheres, dips due to something. And these dips were in fact due to short periods of hypothermic circulatory arrest, albeit not deep hypothermia. But we like to think deep hypothermia is 19 or so. But here at 25 degrees, some hypothermic arrest for a period of time. Down came the cerebral sats, up it goes again when the perfusion is started, down it comes again, up it goes when the perfusion is started. That one there, 1, 2, and 3 on both sides. So there's some global impairment of oxygen delivery to the cerebral hemispheres. So I've spent many hours, many years watching monitors. And those of you who've had a chance to work with me think, what is going through his head? Well, I'm looking for deep C. And deep C, is the process by which things go wrong. And the first thing that goes wrong is diastolic dysfunction. I've told you already this evening the importance of the left ventricle relaxing. Well, the first thing that fails when the ventricle is impaired, its function is impaired, is it doesn't relax as well. You see it with a high venous pressure, you might see it with a high left atrial pressure. Okay, so the first thing that happens, diastolic dysfunction. The next thing happens is you get systolic dysfunction. So stroke volume goes off. And we can identify that perhaps on our echo. We might see some bits of the muscle wall that don't work very well. Or indeed, if the posterior lateral aspect of the left ventricle doesn't work, then maybe the papillary muscles won't work as well. And maybe there'll be some mitral regurgitation. DSE for ECG, where we see some changes in ST segment and trends on the ST segment monitors that we watch closely. And the last is an A, which I say is for angina for the conscious patient, or maybe even arrhythmias for the unconscious patient. So deep C is what I'm always looking for. But what causes deep C? There are, as far as I'm concerned, 5 causes, and every cause I have ever seen fits into one of these categories. And I attribute 2 of them to the anesthesia part of the team and 3 of them to the surgical part of the team. So thinking about our own responsibilities as anaesthetists, I'm thinking physiology and I'm thinking pharmacology. That leaves anatomy, pathology, or surgery to be the other 3 aspects. So let's drill down on that physiology and think about it in terms of our content of oxygen and oxygenated hemoglobin, or the hemodynamics. And let's think of it in pharmacological terms, that we've got the wrong drug. Let me show you some examples and I'll show you what I mean. So in this example, which was taken a long time ago from the operating room, I've got 3 trend recordings: heart rate, arterial blood pressure, and left atrial pressure. And we've come off this was the bypass period up here, okay? And we've come off along There's a systolic, a diastolic, and a mean pressure. And just about here, there's a little subtle rise in the venous pressure. We've got the D of diastolic dysfunction. And as you can see in time, that left atrial pressure becomes really high here when there is now functional mitral regurgitation. So here's a D, and here is an S. The systolic function is going off the boil. Now, I don't know the cause. I can't remember, it's too long ago for me to remember what specifically was the cause of this. But clearly, if we don't do something about it, we're going to end up with worsening ECG, failing heart rate, and arrhythmias or VF. So there's an example of diastolic dysfunction and systolic dysfunction. Now, here's another example where we've got some trend recordings again. Here we've got the pressures, systolic, diastolic, and mean. And things are going off the boil quite dramatically. Things are getting a lot worse. And with them, so too are the ST segments. And if you think about the gradient here, I've got a diastolic blood pressure here of about 40, and I've got a CVP here of about 15. Now, I know the CVP is not the LV-EDP, but nonetheless, 40 minus 15 is 25. And 25 is the sort of the point at which you're on the really slippery slope to see a deterioration in the coronary perfusion pressure. And down it goes still further. And as it goes down, you can see the impact on those ST segments. We've got diastolic dysfunction. The venous pressure's high. We've got worsening systolic dysfunction, and we've got ECG changes that are following suit. So at this point, I remember giving the patient a small dose of phenylephrine to jack up the hemodynamics and crank up the diastolic pressure, and up it goes. ST segments normalize, and over the course of the next 10 or 15 minutes, the venous pressure slowly comes back down to something that's much more acceptable as the relaxation has improved. Okay, let's change tack. This is a preoperative electrocardiogram, 12-lead ECG of a patient who had aortic stenosis with documented left ventricular hypertrophy. Let's have a little look. 1, 2, 3, whoops, daisy. 1, 2, 3, 4, 5, 6, 7, 8. Yes, 40 millimeters. Well, it's more than 35. So they've got ECG evidence of left ventricular hypertrophy. Okay, what's the postoperative ECG looking like? Well, okay, I've only chosen 2 sections here, V5 and V6, V5 and V6, V5 and V6. And there's no question that there are some ST segment changes here, which are a little bit better by this stage. And this is the postoperative day 1 recording. They're plumb normal. And what was the reason for it? Well, this is an example of another physiological cause of some ST segment changes. There was inadequate CaO2. There was saturations were good, but the hemoglobin content was only 50 here, cranked up to 70 and up to 115. And the important point here is because of the left ventricular hypertrophy, the homeostatic mechanisms don't work in the same way as they would without left ventricular hypertrophy. So it's really important to get the hemoglobin concentration right. This was a fascinating lady who was absolutely terrified, petrified of her surgery, petrified of her anaesthetic, and probably petrified of me. And I prescribed her pre-med for 9 o'clock in the morning. She asked for her pre-med at 9 o'clock, and the nurses said, no, we're not going to give it to you. She asked at 10, and the nurses said, no, we're not going to give it to you. By the time she got to 11 o'clock, 2 things happened. The porters turned up to take her to theatre, as she was the second case, and she asked for her pre-med, and they all felt a little bit shamefaced. And this particular lady, as you can see, with her left ventricular hypertrophy secondary to aortic stenosis and coronary artery disease, turns up in the anaesthetic room with a heart rate of 120 and 6 millimeters of ST segment depression. 5.5. Okay. And as you can see quite nicely, just giving this lady a little bit of midazolam intravenously and taking those nerves away, down comes her heart rate and then ST segments normalize. And I think it's rather a lovely demonstration of how this was a physiology that was completely inappropriate for her pathology. Okay, so I'm putting my hand up and say that I've managed more than once to see some physiological. What about some pharmacological causes of myocardial ischemia? This was taken one morning. As you can see, these are definite times, you see. Got into theatre bright and early, before 9 o'clock. Things were looking great. But the blood pressure was going on, there was no surgery, there was no skin incision. Things were looking a bit sort of peaky. And the heart rate nice and slow. And I thought, oh, I know what I'll do. I'll give a little bit of an adrenaline infusion. Oh, it certainly corrected the heart rate. I felt a little bit better about that. It certainly corrected the blood pressure. Okay, I felt a bit better about that. But look what it did. It made the patient ischemic because I'd upset the balance between the supply, which was diseased coronaries, and the demand by changing the tension and the oxygen consumption, as well as the time for perfusion. Okay, those are me. What about you as surgeons? How can you do it? Well, we've got to think about those coronaries you're dealing with, the vessel itself, the wall, the contents, whatever they may be. Let's have a look at some. This was a patient with a type A aortic dissection. And the surgeon was Steve Livesey, and there must have been a trend recording taken many years ago. And we were about to come off bypass, and we had these ST segment changes in leads 2 and lead 3 and lead AVF. In other words, the inferior leads. And we felt, rightly or wrongly, and without any further ado, that the aortic dissection had almost certainly spread to involve the right coronary ostia. So Steve Livesey took a surgical approach, grafted the right, we did another bypass run, grafted the right coronary, and when we came off, those were the ST segments, really rather nicely sorted out. So there's a pathological cause of ST segment changes. Okay, and there are other aspects that are pathological. We can think about the nature of the disease, how it gets squashed, where that coronary artery is coming from sometimes, and what's obstructing it on the way. So this particular patient has had a mitral valve repair. And shortly after separation from cardiopulmonary bypass, we have these ST segment trends that occurred in, again, the inferior leads, leads 2, lead 3, and lead AVF. And of course, you think, aha, the patient is lying on their back. In this instance, there may have been some air left in the cavity of the left ventricle. And if there was some air, it was likely to come out of the aorta, pass anteriorly, in which case, chances are it would go straight down the right coronary, which is an anteriorly placed structure. And indeed, that's exactly what the cause of this was. Transient inferior changes as air goes down the right coronary. Sometimes you might see something as horrible as this. And this shows widespread early, sort of the type of appearance that you think, oh my goodness me, what is going on here? And this particular patient is having an acute myocardial infarction. They've got some hyperacute changes on the postoperative ECG. And there's a likelihood here is that there's been an early graft failure of one sort or another. And this must be taken extremely seriously. I have to add that from my recollection, this early change wasn't acted upon, and the lady died sometime later with a full thickness myocardial infarction and a transventricular rupture. So ignore this type of thing at one's peril. So let's think, we don't want to get to that stage of ignoring things at our peril. We've got to think about managing things when they go wrong. So if we've got a physiological cause, correct the physiology. We could bolt onto that pharmacology used appropriately. We've seen an example of vasoconstrictor used to crank up the coronary perfusion pressure. Or we've possibly used an inotrope carefully to augment the contractility, but not to make the situation worse. Sometimes the circulation is genuinely overfilled, in which case a little bit of glycerol trinitrate might just cause some venodilatation, or you could take off some volume, but via the venous line back into the bypass circuit if the pipes are still in. So if it's a physiological or pharmacological cause, deal with both of those. If it's an anatomical and pathological cause, we've seen with some examples of Steve Livesey's aortic dissection that we need to correct the anatomy. And then if we're stuck, we've got to think, oh my goodness, what's next? We've got a machines sort of coming out of our ears, and one of those is a balloon pump, and one of those is back on bypass. And I just want to show you, if I might, I'm sure you've come across this before, but this is an unusual trend recording because I've got a left atrial pressure wave here as well as a CVP. The LAP is a mean of 15 like the CVP. Both are rather high. And if you can look at this, we've got that we're on the same scales, 0 to 120, 0 to 120. And we've described today the coronary perfusion pressure as being the aortic diastolic pressure minus the LVEDP. And you can see it here. That's the gradient for coronary perfusion. What is the gradient for coronary perfusion with a balloon pump in? Woohoo! Look at this. And look how much bigger it is. And I think you can see so nicely how a balloon pump cranks up the gradient, the diastolic gradient for coronary pressure. So the terminology is important to understand, but it's not important for you to understand at your stages of training, because we talk about balloon diastolic augmentation pressures, assisted aortic end diastolic pressures, blah-de-blah-de-blah. But if I was to leave you with one message, that the intra-aortic balloon pump does this, then my message would have got home well. Now the balloon, the other machine that we might use is the cardiopulmonary bypass pump, and that's just great. And you might just think, well, what is he got a picture of a ventilator that's not doing anything? Well, you know full well what a ventilator that is not doing. It means that we are on bypass, and you'll probably all know what anaesthetists do when we go on bypass. Yeah, we get ready for the next case. So the bypass side of things, I know from Hanad, has been covered in another talk. So I'm going to talk about the preparation for separation from bypass, if I might. And what I do is I instruct my trainees in anaesthesia, and perhaps those of you who might be listening in surgery as well. I think about a history. Oh, how interesting. History, exam, will there be special tests and an examination? Let's have a look. What was that patient's preoperative condition like? In other words, what was their limitation? What was their functional impairment? Were they okay? Did we have to struggle with their hemodynamic management ahead of bypass? Because if we did, the likelihood is we might need a bit of help. Did the pre-bypass period go with, was it okay? No ischemia or systolic or diastolic dysfunction? Any deep C there? Has the surgeon done what they've gone and done? If they've got 3 vessel disease, have they put 3 grafts on? Or are the targets so horrible that they've only managed to graft 1 territory? And in that process of surgery, has the myocardial preservation been good? and not excluding our perfusion colleagues from that history taking. Have they had a good time? Have their gases on bypass been okay? Has their hemoglobin concentration been okay? Has their potassium management been okay? Because those are really all really important. What about the examination? A piece of examination technique that I was taught many, many years ago by one of my teachers was to start on the right and look round to the left. And it stood me in very good stand to do this. So what's on my right is the ventilator. And as I look over, I can see the lungs moving. But when I look over the field, I can see the operative surgeon. And what do they look like? We all know what's a happy surgeon and what's a cross surgeon. And are they happy with their handiwork? And a bit further round to the left in Southampton, the perfusionists sit facing the operating surgeon, not behind, as sometimes happens in Birmingham. So I glance at the perfusionist, and then I continue my journey round up to the monitors, looking at the rate, the rhythm, the conduction, the ST segments. If I need a pacing, what have I got the pacing on? DDD, DVI, DDI. And I'm going to glance at those filling pressures and not forgetting the temperature of the patients, because that's up on the monitor as well. To go hand in hand with all of that, I've got to think about those investigations. Glance at the blood gas analysis, the hemoglobin. Is it a satisfactory hemoglobin to convey oxygenated red cells in a good quantity down the coronary arteries? Is the potassium okay? Long bypass, high potassium, the heart won't go very well until the potassium is lowered. Is the pH all right? And is the activated clotting time still satisfactory within the acceptable range? And then the bottom line is, will I need pharmacological support? And I'm going to choose that on the basis of what I've seen. Best pharmacology, best oxygenated red cell, best inotrope, get that hemoglobin down the coronary arteries. And then let's play with physiology. Let's fill that circulation. Let's watch that left ventricle distend. Let's watch the right heart fill, and let's see the effect of stroke volume on the arterial pressure. So the coming off is a matter of continually stretching those myofibrils and we get optimum preload. And as we do so, we want to watch that gradient for coronary perfusion pressure like a hawk. Is it above that cutthroat threshold of 25 millimeters? Is it better still near 40 or 50 or 60 millimeters? And is there going to be time to get that oxygenated those red cells down the coronaries? Is the heart rate okay? Now, if the systemic resistance is a bit low, then we're going to use some noradrenaline to help tone up the circulation. Now, I've put high afterload in brackets because, frankly, that's pretty unusual. It's normally a complication of something, and we'll come on to those in a bit, as a cause of high afterload. If the heart doesn't go, we need to give some inotropes. And perhaps, for example, if you think about a mitral valve repair, for someone who's had long-term mitral regurgitation, there they've got a ventricle that's had an easy job of it. Every time systole comes along, it's shot back half its stroke volume into the left atrium. It's been a stroll in the park for that left ventricle. Make the mitral valve competent, and that ventricle now has an increased afterload because all of the stroke volume needs to go into the aorta. And the consequence of that is that the afterload rises. And so all patients in my book who have had a mitral repair need a little bit of inotropic help. What if the right heart fails? Well, that's a subject on its own, but there the job is to reduce the pulmonary vascular resistance. So let's imagine now we've come off bypass, and the thing that the anaesthetist has to do is to repair the damage. You perhaps are sewing up the leg vein. We are giving the protamine, optimizing the circulation, transfusing red cells or any blood products, and then making a diagnosis of any hemorrhage, be it surgical or coagulopathy, and sorting out the coagulation disorders upstairs in the operating room before the chest is closed. So let's then move on to the intensive care unit. I've got a question here. This was an old question that was asked of an anaesthetist in something like 2004. And the patient is on the ICU who had cardiac surgery completed 3 hours ago, still intubated, and what clinical features might suggest the development of acute cardiac tamponade? A reasonable question, you might say. And it says, how might you confirm the diagnosis? There was a third part to this question, which I have to say is quite funny, which was, what outline your management? Now, it happened that in one of my teaching groups, one of the audience members was the daughter of a cardiac surgeon. And she put down in her answer, stick a needle into the pericardium. Now, that's not necessarily the best form of treatment when you be mindful that there are 2 or 3 chest drains already sitting in the pericardium, and there you could hit almost anything of import with your needle. So she shamefacedly admitted that she asked her father what she should do, and she, in no uncertain terms, she was told not to stick a needle in. So let's just think about those features about acute pericardiac tamponade. What might we see? Are we going to see deep C? We certainly might. We may see a rise in diastolic pressures. The filling pressures may go up. What about the systolic pressures? Well, they may come down. But don't be fooled, because sometimes the nurses might have given some more inotropy to offset that impairment in systolic function. So that may go underneath the radar. So are there going to be any ECG changes? Quite conceivably. But there may be subtle other changes that represent a failure of forward flow. There may be a reduction in the urine output, a bit of a rise in the lactate. Yeah. So those are what we see, but at the same time, it might be that there's been a background of slowly dribbling drains all along. Slowly dribbling drains are okay. But what's not okay is when slowly dribbling drains suddenly stop. Because the question is then, oh, has there been a clot formed in that heart, around that heart? When you go to that, look at that monitor and you look at it and you think, oh, is that blood pressure? Is it all right? And it says 110/65. What I would commend to you is look at where that dicrotic notch is. If that dicrotic notch is about 1/3 of the way down the slope, the slope during diastole, that circulation is adequately filled. If that dicrotic notch is right down at the diastolic blood pressure, then what you're seeing then is either an underfilled circulation or one in which there is accumulation of a tamponade. The venous pressure may be high, and if you're very clever, you might see a steep Y descent. But those investigations are going to have to encompass a lot of things, not just the hemoglobin and the coagulation, and scrutinizing the blood gases. I'd put a straight line through that X-ray, because if you do an X-ray to exclude a tamponade, you're wasting time. What you need is a TTE or a TOE to actually see that clot or that compression. The alternative is you don't have that kit. And do you know what? You might just have to open the chest, perhaps as part of the resuscitation. But guess what? It'll almost certainly give you the answer. Another question. Does the measurement of the pressure in the SVC accurately represent the right atrial pressure? And I posed this question to myself all day once within the last couple of years. I had struggled with the circulation on a patient who'd had previous cardiac surgery for congenital heart disease. And the only way by which I could possibly keep the pressure in 3 figures was to have a venous pressure of 19 or 20 millimeters of mercury. And when I'd seen the heart, it just did not look like a heart with a venous pressure of 19 or 20 millimeters of mercury. Could I convince myself that the veins in the head were a little bit more filled than they needed to be? Well, when I got to intensive care, I thought, you know, I'm not going to go home without getting an answer here. And so what I did is I floated a pulmonary artery catheter, and it went down the SVC here, went from the RIJ into the SVC. And at this time, the pressure was 19 millimeters. And then it popped into the body of the right atrium, and it went down to 9. So I pulled it back, and it went up to 19, and I popped it in again, and it went down to 9. So I went to the catheter lab, and there was a stenosis in the SVC, which the cardiologist then stented. The venous pressure fell very nicely. The filling of the right atrium improved, and this pressure up here became the same as that pressure down there. So sometimes we need to maintain a high degree of critical appraisal of the numbers that we're looking at. So there's an example there. Another question that perhaps is one of those that might have come your way when faced with that rather scary moment that the pacemaker is not going. What hazards or complications may arise from temporary or epicardial pacing? And I've broken this down in theatre, during transfer, and in the ICU. So in theatre, we might get, you know, it's quite possible to put those leads on the wrong way round. Anything can happen. Get them on right or get them on wrong. Diathermy always interferes with them unless you put it in an asynchronous mode. And how many times have I seen surgeons dislodge wires, particularly the left atrial wire, the right atrial wires, when either pulling a swab out or indeed when taking out the sternal retractor, and the wires are then cut whereas the retractor is removed. In the ICU, the causes aren't quite like that, but pacemakers get dropped. Sometimes they hit the floor, and sometimes the leads pull out of the pacemaker, and sometimes the leads pull out of the patient. So whatever you do, always tie the pacemaker to the bed, okay? Do not have it free so it can fall off. And here's an example of something going a little bit wobbly. What we've done here is just to see, oh my goodness me, we've turned off the pacemaker, and all we've got left with are P waves up here. And P waves, as you know, is not enough to give you stroke volume of any adequacy. And indeed, the blood pressure took a dive like this. And at this point, we turned the pacemaker back on again. So what are the 3 cardinal sins of cardiac anaesthesia? And this is something I have said to my trainees for the last 30 years. And they are, number 1, to fail to give the heparin prior to cardiopulmonary bypass. Number 2, to inadvertently give the protamine when the patient is still on cardiopulmonary bypass. And last of all, to fail to turn on the ventilator before separation from cardiopulmonary bypass. And why are those always all fatal? And they are all fatal because they result in a pretty much instantaneous failure of the delivery of oxygen to the tissues. And it might, it might be something you can remember. You can only ever remember things in 3s, but those are the 3 cardinal sins of cardiac anaesthesia. I leave you perhaps with this diagram, which was something I created a long time ago to help you when faced with that of a falling blood pressure, because that's what the nurses in the intensive care unit will say. They say the blood pressure's down. Well, actually, what you've got to decide is what the cause of that is. We know that the blood pressure is the product of the cardiac output and the systemic vascular resistance, systemic vascular resistance. This times this equals this. So this is dependent upon the heart rate and the stroke volume. So let's just think about that and how stroke volume might be impaired. It might be an inadequate preload, or excessive afterload, or impaired contractile performance. And I've put in those a medical cause, in other words, intensive care, anaesthesia, critical care, and a surgical cause. And this is where the afterload to the left ventricle is too high, where we have something called SAM, or in situations of HOCM. And here's some surgical examples of where the afterload is too low, and some surgical and medical causes of impaired contractility. And over on this side are situations where the systemic vascular resistance may be low. It may be due to the anesthesia technique or some uraxial blockade, or it may be pharmacology, or it may be an inflammatory process. And that is essentially that when it comes to the management of the postoperative circulation in intensive care, is thinking which one of these categories does the problem fit into. Ladies and gentlemen, you've been kind enough to listen to me for just on 60 minutes, and I think that is my last slide. It is.
Thank you very much, Dr. Pearce, for a wonderful talk. We will now take questions. Just whilst people do think of their questions, Dr. Pearce, would you mind just giving us just a quick kind of summary of how the pacing box works?
Yeah, okay. What the pacing box does is it sends an impulse to the various leads. Now, there will be almost nowadays exclusively atrial leads and ventricular leads. So 2 go on the atria and 2 go on the ventricle. The atria that is generally chosen is the right atrium because it's more easily accessible and it's at the front. And the application is then of a certain voltage to those over a very short period, sufficiently amount of time to induce systole in the atria or systole in the ventricles. So that in an ideal world, we'll then get atrial systole followed by ventricular systole. Now, as you saw from that ECG example I showed you, might just flick back here. So let's go back to this one here. You'll see that the QRS complexes are often widened when the ventricle is being paced. And the reason for that is that the depolarization travels through ventricular muscle rather than through the faster acting His-Purkinje system, which it would have done if it had come via the atrial, from the atria and the AV node. So the QRS complex is often wider, and that actually sometimes can impact upon the coordination of ventricular contraction as well. Now, as hand in hand with its ability to contract or to put a stimulus out, the pacemaker also has to be aware that it has not to crosstalk with either the patient's own generated QRS complexes or atrial rhythms, or an ectopic source. So they have to know when not to pace as well. And the reason we want things not to pace is that if you pace inadvertently on a T wave, we produce what we call an R on T, and that's the vulnerable part of the QRS complex. And as a result of that, you might well end up by putting the patient into ventricular fibrillation. So they have to hand in that, put a sort of a way of detecting. Now, how do you know it's detecting? Well, very often from the 3-letter code, there is an I, AAI, or DVI, or DDI. And that I means that in response to a patient-generated QRS complex, the pacemaker will inhibit its output. When I mentioned briefly an asynchronous mode, and that's an asynchronous mode is coded DOO. And that's it's very useful when there's a lot of diathermy, but it's very dangerous because the pacemaker, you've turned off the inhibiting and sensing function. And so when you glance at a pacemaker, look at it. Is it atrially pacing, AAI, or is it dual chamber pacing, DDI, or is it another, and two other forms of dual chamber pacing are DVI and DDI, and the other one is DDD. So that's the, I think, important point, is always look at the last letter. Is it going to inhibit when a patient has their own QRS complex? The other thing that you need to think about that's worthy of evaluating and recording every day are the thresholds. In other words, the minimum voltage that is needed to be generated before a QRS complex is generated by the heart. Now, technically, this should be around about 2.5 to 3.5 volts. Leave the pacing leads in for a long time, and relentlessly that threshold rises. And it's really important to be able to be aware of that. And my advice to you all is to document it in the notes every day with the monitor on, so you can see when it cuts in.
Thank you so much for giving up your time this evening, Dr. Pierce.
That's not a problem at all. I wish you all well in what is a very competitive market. I'm sure it will, it's look after your anaesthetists. And I think I've looked after my surgeons that I've worked with. I hope they'd say so. It's been 30 years of immense fun. And it's lovely to see today the next generation following up